guys, welcome to your online lecture, Care of Clients with Fluid and Electrolyte Imbalances. So just remember back to what is homeostasis. So it's a state of equilibrium or balance within our body. It's naturally maintained through a variety of adaptive responses, and it's really important that we have a closely regulated environment internally within our bodies. Volume of fluid and composition of electrolytes is a part of homeostasis, and any alteration in fluid and electrolyte balances are associated with certain disorders, and with certain disorders we can provide various treatments. Approximately 60% of our body weight in adults is water, or approximately 80% in infants. Elderly water content is approximately 50%, which is a lot lower than that of adults and infants, which puts them at high risk for dehydration. Water content varies with gender, body mass, and age. Water is the solvent in which our body salts, nutrients, and wastes are dissolved and transported around our body. Water works by regulating our body temperature, lubricating our joints from head to toe, reduces the burden on our kidneys and liver by flushing out waste products, carries nutrient and oxygen to the cells, helps dissolve minerals and other nutrients to make them accessible to our whole body, helps prevent constipation, protects our body organs and tissues, and moistens tissues for our mouth, eyes, and our nose. Body fluid compartments. The two major body fluid compartments are intracellular and extracellular. You can probably remember back to patho when this was discussed last semester, and will likely again be discussed this semester. Intracellular fluid is within our cells, and approximately 2/3 of our body's water is located there. Extracellular fluid is the fluid spaces between our cells. Also our plasma. It's composed of primarily saline. 1/3 of our body water, or 17% of our body weight, comes from extracellular fluid. And then we have our transcellular space, which includes our cerebrospinal space, our GI tract, pleural, synovial, and peritoneal spaces, and is comprised of approximately 1 liter. The body's natural response to balancing fluid volume is through the following: hypothalamic regulation and adrenal cortical regulation. In regards to the hypothalamus regulation, an increase in plasma osmolality, or fluid deficit, is sensed by the hypothalamic receptors, which stimulate both the thirst receptors and the release of ADH. Thirst causes the person to drink water, while ADH, released by the posterior pituitary, comes to help as well, causing water reabsorption in the renal and distal tubules. The result is fluid retention. Once the body's plasma osmolality decreases, the hypothalamus stops sending the signals, and the body resumes normal homeostasis. In regards to adrenal cortical regulation, the two hormones released by the adrenal cortex are glucocorticoids and mineralocorticoids. They regulate water and electrolytes. Glucocorticoids, also known as cortisol, have an anti-inflammatory effect, increasing serum glucose. Mineralocorticoids, known as aldosterone, enhance sodium retention and potassium excretion. The secretion of aldosterone is stimulated by a decreased renal perfusion. The kidneys then respond by secreting renin into the plasma. Most electrolytes are maintained through the function of the kidneys, and they filter about 1.5 liters of fluid each day. The renal tubules reabsorb water and electrolytes and secrete waste to maintain normal plasma osmolality, electrolyte balance, blood volume, and our acid-base balance. Substances whose molecules dissociate or split into ions when placed in a solution is known as electrolytes. Ions are electrically charged. They can be cations, which are positive, or anions, which are negative. Active chemicals that unite in varying combinations in the body. Intracellular fluid. The main cation, or positive ion here, is potassium, and the main anion or negative ion here is the phosphate. In regards to our extracellular fluid, the main cation is sodium, and the main anion is chloride. Different processes move electrolytes and water between the intracellular fluid and extracellular fluid. In regards to electrolytes, we can think back to patho in regards to diffusion, facilitated diffusion, active transport or sodium-potassium pump, osmosis, and hydrostatic pressure and oncotic pressure. You can review those independently in your textbook. They will not be tested for purposes of this class. For a review of osmosis, diffusion, and active transport, you can review this YouTube video. Movement of fluid and electrolytes continued. Osmosis is the movement of water between two compartments separated by a membrane permeable to water but not a solute. Water movement is driven by the force within the compartment, the osmotic pressure, which is exerted by colloids in a solution. The major colloid in the vascular system is protein. Protein attracts water, pulling fluid from the tissues into the vascular spaces. If capillary and interstitial pressure is altered, fluid can shift. Fluid might shift from one compartment to another, which results in edema or dehydration. If the shift of plasma is into the interstitial places or interstitial fluid, then edema occurs. If the shift of interstitial fluid, goes into the plasma, we get dehydration. Plasma to interstitial fluid shifts result in edema. It's caused by an elevation in venous hydrostatic pressure, so patients who have congestive heart failure, liver failure, or fluid overload. A decrease in plasma oncotic pressure, as in protein loss from renal disorders and malnutrition. Or an elevation of interstitial oncotic pressure, such as trauma, burns, and inflammation. Interstitial fluid to plasma shifts can be caused by fluid drawn into plasma spaces whenever there is an increase in plasma osmotic or oncotic pressure, so when we administer IV solutions. Increasing tissue hydrostatic pressure forces fluid into the plasma when we wear compression stockings or hose. When we talk about fluid spacing, we talk about first spacing, second spacing, and third spacing. First spacing is the normal distribution of fluid in ICF and ECF. Second spacing is when we start to see abnormal accumulation of interstitial fluid, such as edema of the legs or extremities. Third spacing is fluid accumulation in part of the body, such as the peritoneal cavity, so the abdomen, the pleural cavity, lungs, or the GI tract, where it is not easily exchanged with extracellular fluid. Fluid and electrolyte imbalances occur to some degree in most major illnesses, injuries, and surgeries. They can be caused by therapeutic measures, such as giving too much IV fluids, too little, or the administration of certain medications. Think back to Lasix and how that affects our electrolytes. Remembering that the major cations are sodium, potassium, calcium, and magnesium. Our major anions are bicarb, or acid-base, chloride, and phosphate. The disruption in the normal homeostatic mechanisms can cause an alteration in fluid and electrolyte imbalances, commonly classified as deficits or excesses. Another example would be NG suction. Although it's a therapeutic measure, it can lead to the loss of sodium, potassium, hydrogen, and chloride. This would be commonly classified as a deficit. Changes in the osmolality of the extracellular fluid alters the volume of our cells. If we have an increased extracellular fluid osmolality, we don't have enough water. Our cells start to shrink, and water is pulled out of our cells and into our vascular system. If we have a decrease in extracellular fluid osmolality, we have too much water. Our cells start to swell, gain, or retain excess water. Water moves into the cells and out of the vascular system. Hypertonia, hypotonic, and isotonic solutions. This makes you look back at the IV solutions we use and starting to remember about which ones are hypertonic, hypotonic, or isotonic in nature. Causes of hypovolemia, so not enough fluid. The main cause would be fluid loss from hemorrhage, polyuria, or too much urination, vomiting, diarrhea, fistulas, fever, excessive sweating, excessive NG suctioning, overuse of diuretics, and alcohol. The second cause of hypovolemia is not having enough intake from dysphagia, unconsciousness, or a lack of available fluids. And finally, the third cause is fluid shifts from extracellular spaces in the burn patient or trauma patient. Symptoms that the patient may experience include low blood pressure, increased heart rate, poor skin turgor or tenting of the skin, thirst, dry mucous membranes, decreased urinary output, and severe hypovolemia can lead to hypovolemic shock. If you minus this PowerPoint, there is a YouTube video you can watch about hypovolemic shock. But for those of you who are more visual, I've included some pictures. The treatment is fluid administration. How? Well, IV, of course. If the patient can tolerate oral fluids, we would give them oral fluids, but quite often patients with hypovolemia need some IV rehydration. If the loss is related to hemorrhage, the patient may need blood products. And then we also really want to treat the underlying cause. So if the cause is vomiting, we want to give antiemetics. If the cause is severe diarrhea, we want to give antidiarrheals. Hypovolemic shock, if it progresses to this state, we really again want to look back and treat the cause and give meds and fluids as needed to increase the patient's blood pressure. The patient in hypovolemic shock will often need care in an intensive care unit setting. On the opposite end of hypovolemia, we have hypervolemia, which is an increase in volume. This increase in volume can be a result of edema or accumulation of fluid in the tissues. The terms you need to remember are dependent edema, pitting edema, anasarca, ascites, pulmonary embolism, and localized versus generalized edema. Causes of hypervolemia might be kidney failure, heart failure, liver failure, excessive intake of sodium or salt, or excessive fluid intake, whether that be by mouth or IV. Your patient in hypervolemia may look like this guy right here. The patient might be short of breath, have crackles in the lungs, tachypnea or increased respiratory rate, abounding rapid pulse, high blood pressure, distended neck veins, and edema. The edema might be localized to the extremities or might be generalized. The treatment is at identifying the underlying cause, whether that be renal, cardiac, an intake issue, or medications, and then we want to treat that underlying cause. A part of the treatment for hypovolemia includes restricting intake of fluids and restricting intake of salt. A lot of patients who are on a cardiac diet or suffer from congestive heart failure, in which they do have hypervolemia, we put them on restricted intake. We also give these patients diuretics to help get some of that fluid off. So this is just remembering back to your electrolytes. Again, this goes to patho last semester, and the main electrolytes that we're going to talk about this semester, both anions and cations. Our bicarb, our chloride, our phosphate, our protein, our potassium, our magnesium, our sodium, and our calcium. We'll start with our sodium. Hyponatremia is water excess. A normal sodium is something that you need to know. So please review the normal sodium levels. You will also need to know the normal values for potassium. The patient who has a low sodium might experience some of the signs and symptoms noted in these slides. Hypernatremia, or too much sodium, is caused by a water deficit. Think about it. If you drink lots and lots of salt, or you eat salty foods, you will be very thirsty because you don't have enough water. If the sodium level is greater than 145, we consider the patient to have hypernatremia. The causes include dehydration, diabetes, osmotic diuresis, IV hypertonic solutions, and the clinical manifestations are thirst, dry tongue, agitation, weakness, and seizures. For those of you who like mnemonics, you can think of the mnemonic fried. The nursing management of the patient suffering from a sodium abnormality includes adequate assessment of intake and output, monitoring for cardiovascular changes, respiratory changes, and neurological status, weighing the patient daily, making sure to make note of any increased weight, skin assessment, and carefully monitoring IV solutions. This means put your patient on an IV pump. We shouldn't run things at gravity. Next, we'll move on to potassium. We can have either a low potassium or a high potassium level. Generally, a potassium of less than 3.5 is considered low. If we have diarrhea or vomiting, we excrete potassium through our emesis or loose stool. When we are on diuretics, when we sweat a lot, when we have dialysis, when we are starved, and during tissue repair, we lose potassium. Majority of potassium excretion occurs through the kidneys. Here's a picture of a patient who is suffering from potassium deficit. On the other end of the spectrum, we have hyperkalemia, or too much potassium. That would be noted generally as a potassium greater than 5.5. If we have excess intake of potassium, maybe we're eating too many bananas. If we're taking potassium-containing medications, if we have acidosis, a crush injury, or renal disease, we might have too much potassium. And this is what our patient looks like with a potassium abnormality. Again, I'm going through these slides a little bit quick, but that's because this is very much a review from last semester. When we have a patient who has issues with their potassium, we may need to either add or take away potassium. We can actually add potassium or KCl to IV solutions, but we should never, ever, ever push potassium. We also need to monitor the patient receiving potassium for cardiac dysrhythmias. Sodium and potassium are the common abnormalities, but you should read and familiarize yourself with calcium and magnesium as well. And look over the short section on protein imbalances. There really won't be many, if any, questions on your exam about these, but the sodium and potassium you will definitely see. Whoops, sorry here, let me go back. Calcium, I've given you a little picture of here because I said to briefly review that. And magnesium, a little picture there. And here's a slide that puts all your electrolytes together that you need to know, why they're good, and information regarding supplements. Acid-base balances is a balance between acids produced during metabolism and bases that neutralize and promote excretion of acids. Kidneys are the essential buffer system for our acids. Remember, an older adult has decreased kidney function and decreased respiratory function. This means that they can't compensate as well when they suffer acid-base imbalances. Some health problems that patients can suffer from also lead to acid-base imbalances. Acid-base imbalances are our ABGs. Conditions such as diabetes, COPD, kidney disease, and vomiting and diarrhea are the most common health problems in which we will see an alteration in ABGs. One of the other ones that we're seeing a rise in is our mental health problems, specifically our drug overdoses. So this is just a little slide, 1, 2, 3, how to look at your ABGs. So remember, if our body is acidic, we have an increase in our hydrogen ions, and our pH is generally less than 7. Although a normal pH is 7.35 to 7.45, anything less than 7.35 we would consider acidotic. However, a pH less than 7 is extremely acid and is often non-compatible with life. Usually acidotic states are produced by some sort of metabolic process. A base is a decrease in our hydrogen ions, which drives our pH up. A pH of 7 is considered neutral. A normal blood pH is 7.35 to 7.45. The body has three mechanisms to regulate acid-base balance: the buffer system, the respiratory system, and our renal system. Oops, sorry again. In respiratory acidosis, we have CO2 retention. We have CO2 retention because the patient is not breathing off that CO2. As a result, carbonic acid starts to accumulate, our pH drops. We know if we have a low pH, we have acidosis. If we have an alteration in CO2, it's related to respiratory. If we have an alteration in HCO3, it's related to metabolic. The most common causes of respiratory acidosis are COPD, they're CO2 retainers, sedative overdose, because they tend to not breathe as much, severe pneumonia, and atelectasis. Low pH, high PCO2 equals respiratory acidosis. Respiratory alkalosis is the opposite. The CO2 excretion is increased, and as a result, our CO2 levels drop, usually caused by hyperventilation. The patient hyperventilates, blows off that CO2. As a result, it drops. Subsequently, increase in pH related to carbonic acid deficits. The compensatory response of HCO3 excretion by the kidneys causes our hyperventilation, so fear, anxiety, pain, fever. Or if the patient is on a vent and they are overventilated, they will have respiratory alkalosis. High pH, low PCO2 equals respiratory alkalosis. So we'll briefly talk about metabolic acidosis and metabolic alkalosis. Again, there's a completely separate ABG PowerPoint, and I will review ABGs again in class last week, and I also know this is something that was touched on in your patho class. So metabolic acidosis, acid other than carbonic acid accumulates in the body, or bicarbonate is lost from bodily fluids, which causes the HCO3 to be low. The compensatory response of CO2 excretion by the lungs. Causes of metabolic acidosis includes diabetic ketoacidosis, lactic acidosis, starvation, severe diarrhea, renal failure, and shock. Low pH, high HCO3 is metabolic acidosis. Alkalosis is the opposite. We get a loss of a strong acid, usually caused by prolonged vomiting or gastric suctioning. High pH, high HCO3, metabolic alkalosis. I know this is kind of a lot to cover and it doesn't make much sense as I go through it with my PowerPoint, but I am hoping that when I review it in class next week, it will all start to come together for you. Something you do need to know is your arterial blood gases. So your normal values, your pH is 7.35 to 7.45. Your carbon dioxide levels, or CO2, should be 35 to 45. How I remember that is 7.35, 7.45, 35, 45. Just kind of similar. And your bicarbonate, or HCO3, is about 21 to 28. Again, depending on the lab, the results will vary slightly. The next two slides are just kind of like a neat chart for those of you who like to see things more visually. So think of it this way. If it's a respiratory issue, so respiratory acidosis or alkalosis, the numbers, the pH and PaCO2, will always go in the opposite direction. Think of respiratory carbon dioxide. Metabolic acidosis or metabolic alkalosis will have numbers that always go in the same direction, either up or down, and will always relate to HCO3. Again, something I will review next week. This is just a little ABG cheat sheet for you. I think it will be very useful in your studying practices. So let's review the nursing care of patients with fluid and electrolyte imbalances. So we need to carefully monitor intake and output, monitor vital signs, Monitor their respiratory and neurological status. Weigh the patient daily. The patient should report any increase in weight. Skin assessments. Careful administration of IV fluids. This means putting the patient on a pump. Watching our tube feeds. Checking our lab values, specifically our electrolytes and our ABGs. Providing IV therapy in an NG tube as needed. This brings you back to AHA, just remembering what isotonic versus hypotonic and hypertonic solutions are. And this is just a chart of the various solutions. Top 5 fluids you will see in the clinical setting include normal saline, D5W, Ringer's lactate, and D5 half normal saline, and why they're used. You should review these tables in your textbook. They're really important for your review for test-taking purposes. And that is it for today. So I know this was a lot of information, a bit overwhelming for an online lecture, but I'm hoping that as we go on throughout the next couple of weeks, all of these little pieces will start to be put together or reiterated, because this is not new material, and it will allow for a better understanding of the content. Thank you and have a good week.